Good evening, colleagues, ladies and gentlemen. For those of you who don't know me, my name is Niehaus. I'm the Vice Dean for Research and Internationalization of the Faculty of Medicine and Health Sciences of Stellenbosch University. I would like to extend a warm welcome to everyone here present on this evening, on this wonderful occasion where we celebrate Prof. Niehaus's professorship. A special word of welcome to Professor Sibusiso Moyo, the Deputy Vice Chancellor for Research, Innovation and Postgraduate Studies. Thank you for joining us this evening. And of course our candidate, Professor Dana Niehaus. And a special word of welcome also to Prof. Niehaus's special guests, including his wife Anita and daughters Danielle and Carla. I hope I pronounced the names correctly. We also welcome all guests from outside the university and our colleagues from Stellenbosch and the colleagues from the faculty. So as you know, our inaugural lecturers are an important and a central part of our university's academic life. We commemorate the inaugural lecturer's appointment to full professorship. And this is a very important and defining moment in the career of an academic. So a very important and joyous event in our academic calendar. It says that you've made a significant contribution to your field of science and your field of research and the academy. So an inaugural lecture provides the platform for the candidate to tell us and to tell the colleagues and their family and friends who they are and to present the body of research that they have been focusing on during his or her career. It's thus a celebration of achievement, it's a celebration of academic and academic recognition, and as such it's really a special occasion, and we're very happy to be here this evening. We're glad that you're all here to share this special event with Professor Niehaus and with the rest of the faculty. So we are currently on load shedding and the generators are on, so when we switch over there might be a slight dip in the lights. Please don't worry, the normal power will switch on afterwards, so don't be scared if it's a sudden darkness. I hope you enjoy the evening and would like to now hand over to our Dean, Professor Elmi Miller, to please introduce the candidate.
Good evening, ladies and gentlemen. It's a real pleasure to introduce Dana Niehaus. Dana completed his undergraduate studies at the University of the Free State, and after an additional 2-year research stint, which he focused on Fabry's disease at Mount Sinai School of Medicine in New York, he commenced his training here back at Stellenbosch at the Department of Psychiatry. And subsequently, he spent the last 23 years in a dual role of being an academic and a psychiatrist at Stickland Hospital. He first ran the acute female service and later became a subspecialist in the psychogeriatric services. He also in this period then completed his doctoral degree in psychiatry. He focused during this degree on the endophenotypes in schizophrenia as part of a 2 multinational schizophrenia genetic study. Furthermore, in cooperation with the University of Tampere in Finland, they explored facial affect recognition as an endophenotype. Now, the role of facial affect recognition in illness processes has remained a very central theme in the work area that he has covered, and has been very important in the issue around serious mental illness. Very importantly, in 2013, he had his first dedicated maternal mental health clinic, and he established then a research program at Stickland Hospital focusing specifically on mother and baby well-being and on mothers with mental severe illness. There are many neurodevelopmental and psychological health parameters that had to be assessed in this cohort, and he has been working on this for a very long time now. And we are really looking forward tonight to also hear more about some of this research. Dana has played a very important part in our faculty. He has supervised 25 master's degrees, 7 PhD candidates. He has co-authored more than 100 peer-reviewed journal articles, and we have been relying heavily on him in the training of our postgraduate students. As Nico said, Dana is married to Anita, and they've got 2 children, so we welcome you all. And thank you, Dana, for doing this very important lecture. We're looking forward to hear more about it. And thank you also for the wonderful service you perform in our faculty.
Professor Moyo, Professor Miller, Professor van Gijp-Peteers, and Professor Sidat. It's a great honor to be here today. I think for me today, it's important to realize that we have a work persona and we have a kitchen persona. And what I would like to do today is talk about the yin and the yang of research. And it's important to realize that when you do research, sometimes you have to change the yin to a ying with a G, just so that the balance looks better in your research protocol. So I'm going to take some artistic freedom tonight in addressing some of the results and studies that we have done. And this is the ideal moment to show the yin and yang of research. So the yin, which is female and more darkness orientated, is that I don't know if you know, whether you know that there is no SU policy that allows you to skip this inaugural lecture. I have tried. Okay. But on the yang side, I'm honored to be here tonight and I hope you're going to enjoy this journey with me. So why did we do it? Well, the yang part of it is that maternal mental health is at risk during pregnancy and also postpartum period. Indeed, the first month after delivery, the mum is at a 50% increased risk for psychosis, for example. What is the yin part of this? Well, I've been hoping for a sponsored trip to Finland, and I'll explain later how that worked. And of course, it makes it much easier every 6 months when you report to Professor Sidat to say you're still busy with research. Then you don't get new portfolios in academics. So where and how did we do it? Well, we started the maternal mental health clinic at Stickland Hospital, and I share it with these wonderful colleagues of mine. And if you can't identify yourself on these pictures, please update your departmental website photo. So this is the maternal mental health clinic at Stickland Hospital. Then we also had the Well Baby Clinic in Belleville that partook as one of the recruitment sites, and then Dr. Elsa de Tooy, who's here tonight, started the Sophia Perinatal Psychiatry Center. So there were 2 core studies that we looked at. One is 40 weeks of pregnancy, and the second one is plus the first 1,000 days postpartum. But on the yang side, what we actually needed to say is that it's 46 weeks of pregnancy, but that doesn't sound right, because it's 40 weeks plus 6 weeks postpartum, and that the 1,000 days postpartum is actually 1,460 to 80 days, because we're actually pulling them through to 4 years. So what is the 40 plus 6 study? It was a prospective naturalistic study that formed part of the PhD work of Dr. de Tooy. And we look at the outcomes of pregnancy from conception or first presentation to maternal mental health services until 6 weeks postpartum. We used the DSM-4 diagnosis of TR diagnosis of psychiatric illness. And we had state sector private clinic in combination as recruitment sites. And patients were seen during care as usual visit, once per trimester and then 6 weeks postpartum. So how did these participants present? Well, importantly enough, major depressive disorder was the most common disorder that we found in the mental health cohort. 50% of these individuals only presented after their first trimester to the mental health services. And this is a very important concept to understand, with a mean of about 17 weeks, and some presented as late as 38 weeks of pregnancy. Of the 263 individual women, we had 280 pregnancies over the period of 6 years, of which 15 women had 2 pregnancies during the 6 years, and 1 woman had 3 pregnancies during the 6 years. and almost half of these pregnancies were unplanned. So if we look at planning and the value of planning, it's not a dichotomous viewpoint. It's not planned versus unplanned pregnancy. It becomes more complicated. Is it an intended, planned, wanted pregnancy? Or can a unintended, unplanned pregnancy become a wanted pregnancy? So you need a more nuanced way for looking at planned versus unplanned pregnancy. And this is where we use the London measure of unplanned pregnancy, which looks at contraception use of the mother, the timing of a pregnancy, the desires regarding the pregnancy, whether she had the intention to have a baby, what is the attitudes towards the pregnancy. And then, very importantly, partner involvement. How much partner involvement was there, and what is the antenatal health decisions that the mum made? Taking these in consideration, when you look at the dichotomous view in this sub-study, it was still about 40% that was unplanned. But if you look at the more nuanced way of looking at planned and unplanned pregnancy, we saw that half of the females fell outside of the planned pregnancy category. And 3/4 of those used no contraception. And only 1/4 of them had the agreement of their partner that they're going to commit to a pregnancy. If this baby was unplanned, 80% of the cases this was an unwanted baby. If the mum was ambivalent, 60% of these pregnancies were unwanted babies. But there was unplanned risk factors, independent risk factors that predicted this. And these independent risk factors include things like level of education, so lower level of education, as well as looking at substance use patterns, and then also marital status, and interestingly enough, previous suicide attempts was an independent risk factor for an unplanned pregnancy in this study. So if we look at suicide, and this is Dr. Esma Jordan, bless her soul, she's a biostatistician from the Medical Research Council, and I can assure you that there's no one as patient as Esma, trying to explain to me the statistical analysis that's needed for some studies, and when my eyes glaze over, she just soldiers on. Esma, I owe you greatly for your dedication to psychiatrists' knowledge of statistical analysis over all these decades. But suicide per se is the 4th leading cause of death in the reproductive woman. And in our sample, 1/4 of the mums had a lifetime attempted suicide. And there were multiple suicide attempts, of which overdose was the most common one associated with these attempts. 1/4 of mums during their period in this cohort had suicidal ideation, either passive or active. 7 attempted suicide over the study period, which calculates to about 1 suicide event per 55 weeks of pregnancy. So what did we learn from this? I think what we learned from this is that you need to use multiple assessment tools. Mums made a close part of the information during the clinical interview, additional information during, for example, the Madras rating scale, and additional information doing a mini structured interview. And if you take all of this information together, it's only then that you can clearly identify the individuals that is at higher risk. But above all, the single most important risk factor remains the presence of previous suicide attempts. And this is the risk group that we need to be very careful managing in a psychiatric treatment plan. You know, there's lots of ambivalence and lots of debate about whether medication, psychotropic medication, should be used during pregnancy. And often people would say, no, I prefer not to take medication. But then interestingly enough, 2 out of 5 who were smoking tobacco, 1 out of 5 were using alcohol, 2 out of 25 were using methamphetamine, and 3 out of 5 was using cannabis. So where are we in terms of succeeding in conveying the important message regarding the risk factors? And these risk factors, substance use is a risk factor for unplanned pregnancy. So Dr. Kathy Farmer is currently busy with her master's degree looking at the use of psychotropic medication in this cohort. And to summarize it, 1 in 5 of these mums are exposed to polypharmacy. And polypharmacy being more than one drug used consecutively for over a period of 90 days, of which antidepressants is the most common drug used in this cohort. So then at least we move to a joyous, albeit unplanned, day. And from the 280 pregnancies, we had 284 babies, which means we had the 4 famous twins. And I'll tell you a story about the twins later on. So the babies were born average on about gestational age of 38 weeks, 3.1 kilograms. Interestingly enough, cesarean sections, elective cesarean sections was quite common, and emergency cesarean sections as well. About 57% of the mums breastfed with or without additional supplementation. So what did we do in the next 1,000 days, or 4 times 365 days? Well, can I introduce you to the marshmallow auntie? So the marshmallow auntie, Gerdia Harvey, she's now on a 6th PhD, né? And I think we all owe her our PhDs for the miraculous work that she does with toddlers and mums. So what Gerdia has helped us as the research assistant is to look at different aspects over this 4 year. We look at DNA analysis, neurodevelopmental assessments, vocalization of babies, behavioral changes, theory of mind test, video recordings and measurements on that, some attachment work, eye tracking, facial affect recognition, and pupil dilatation. So a range of age and developmental appropriate techniques that was followed. So I can tell you an interesting story about one of the twin pairs. So one of the twins, we've got a part of our study where there's a separation from mum to see what the reaction of the baby is. So twin number 1 was exposed to separation from mum, but then promptly informed his co-twin that he must be careful, they're going to take his mum away when they visit next time. Which of course led to twin number 2 crying blue murder on the day that he had to be tested. So I think it's those unintended consequences of having twins in a cohort study. So Janne Voges did an associated or part a sub-study where she looked at parental reflective functioning. And parental reflective functioning means the ability of us as parents to look at the baby and ourselves from what is happening in our inner state, how we're experiencing it. And to summarize 4.5 years of work in one sentence. The important thing is that with mums with postpartum or peripartum psychosis, they've got less ability to have parental reflection. But importantly, they have the potential for reflective parental functioning, which leaves us an opportunity to intervene in mums suffering from psychosis. Madeleine Berger then went further and she looked at neurodevelopmental markers in our toddlers. And I'm going to just focus on one aspect of her PhD. Excellent work that she's done. And this one aspect has to do with motor behavior in infants. And she looked at young infants, 10 to 20 weeks, and saw that there was no significant impact on their motor behavior if they were exposed to psychotropics. And that's an important finding because that harks back to our previous concerns regarding the use of medication during pregnancy. But you also followed these youngsters up through 6 months, 18 months. And this specific finding that for me is interesting and thought-provoking is that toddlers exposed to persistent anxiety and mood disorders scored better on the Bailey's subscales of cognitive, motor, language, fine motor, and gross motor scale scores versus babies or toddlers that was not exposed to maternal mental health disorders. So why would this be happening? And there's different reasons why this is possible. One is that it could be the effect that moms knew that she was following up the baby for neurodevelopment and therefore compensated in their day-to-day behavior with the babies, or more likely, that it could be the parental coping styles, that mums may be overprotective or intrusive in how they rear or approach the babies. So Maleta, I don't want to disappoint you, but I always think one needs to take one message to the clinic. And I thought long and hard, how can we do screening for motor behaviors in toddlers in a very cost-effective way? And I came up with it. We're going to buy a car seat for each of the clinics. And we will measure the neurodevelopmental abilities of the babies based on the decibel vocalization when you try to strap them in, and secondly, the sweat pattern and the number of swear words uttered by the parents. Very cheap and reliable to measure. You see, because when we look at this is Santeri. You know, the eye is the window to the brain, and now we're moving to the group from Finland. You hear there, Finland? My special sponsored trip is finally getting into this talk. So the eye is the window to the brain. And some of the work that we're doing, which I find very interesting, has to do with affect recognition and our response to the affective cues that our babies are giving us. You know, it's quite clear that when you see a baby crying as the partner, it may be that our oxytocin is not as high, then I want to run and I get very anxious and apparently my pupils will dilate voluntarily because I can't suppress it, because it's about the autonomic response that my pupils have on seeing these so-called negatively balanced or fearful responses or faces. And what Santeri has shown very, very neatly is that there are more pupil dilation when the mother is exposed to strong negative and mild negative facial cues from their babies. And you know what's interesting about that for us is that it becomes more complicated, because we would think, because it's automatic response, that this will then be evolutionary conserved. But in a collaborative study with Dan Stein's group at UCT and the Finnish group, we looked at a community sample from different socioeconomic strata. And interestingly enough, the pupillary response seemed to be more pronounced only in the high-income group, suggesting that there's a differentiation in a possible neurophysiological response based on socioeconomic variables. Why would this be happening? We don't exactly know, but one can theorize that it costs you more financially to worry more easily about your children's responses. And when you are basically trying to survive, the baby really needs to cry a lot to trigger that response, because it's about basic survival. This is one of the hypotheses that we can play around with. Then we move over to something completely unrelated but also related. You know that when we talk about communication, we've been talking about communication all the time now. When we talk about communication, non-verbal communication is the important aspect. This is a very nice study done in cows. showing that if you look at the non-verbal behavior of your local dairy cow, there are different affective states expressed. Okay. So for me, the message about this is if this happens in animals, it tends to happen in humans as well. And also, very importantly, if someone calls you a cow, they may merely be complimenting your non-verbal skills. So, if we look at non-verbal skills and the ability to pick up these emotions in human beings, we consider these as the so-called 6 basic emotions, work done by Ekman, etc. And if we look at these basic emotions, it's the ability to depict these emotions, including disgust, happiness, sadness, anger, fear, and surprise. And each of these has got a very specific facial script. You need to be able to look at the whole face to get the emotion that's expressed, the correct emotion. And if you're wearing masks during COVID, you're getting half the message, interestingly enough. So we were interested in what happens when mums have to identify facial expression on babies' faces. And this is work done by Dr. Belinda Brouwer. So Dr. Belinda Brouwer looked at facial affect recognition in mums with maternal mental health disorders. And she did a little latent class analysis for which Esme or Dan explained many, many times to a dazed audience what we're supposed to do. But we managed with her help. She identified 2 classes. And interestingly about these classes, there's the first class, which seems to be the majority of mums in our cohort, which had a high endorsement for your positive and negative facial expressive emotions. But then she identified a second class, which is a smaller class, about 1/5 of the sample. And this class had clear difficulties with facial expression recognition on baby faces. And this is important because you hear the message through this talk. There are always a smaller subgroup. And it's the smaller subgroup that we are very interested in because they can be the high-risk group. And what the smaller class showed us is when we looked at bonding and attachment scales, they tended to be the group that performed worse on both bonding and attachment assessments. But they were also the group of mums with the higher depression scores, and they're also the group of the mums exposed to more life events. 7 serious life events versus just a little more than 2 in class 1. Again, identifying some potential risk factors that you and me can use in our clinics on a daily basis to help us identify and optimally manage our patients with mental health disorders. The next question I need to ask myself is a PhD compatible with a Duchenne smile? That was the next question. And luckily enough, we've got some examples. So what is a Duchenne smile? A Duchenne smile is a true smile. You know, it's involuntary and it's real. So what's a real smile? A real smile involves a cheek lifter, but then also a little bit of a crow's feet. And so only if these 2 are together that it's a true, real smile. Okay? And by the way, only about 10% of the population is estimated to be able to fake a Duchenne smile. So why were we interested in a Duchenne smile? Because Dr. Anusha Lekman begged me to do a PhD on our group's work. And when we finally gave in, she looked at shared pleasure moments. So what's a shared pleasure moment? It's the most wonderful thing. That's when the parent and the child shares a positive affect in synchrony. What does that mean? I look at you, you look at me, we both smile. It's as simple as that. And she did that on 5 minutes of free didactic play videos that was recorded. To bring it home to us, because I always believe we need to bring something home to ourselves. There's a very nice study that looks at something else in marriages. So what's a shared pleasure moment in terms of your marriage? Is that thing that disappeared from your marriage. Unless, like me, you are happily married. My wife believes that I'm doing all this research because I'm unhappily married. That's not true. I've got 2 daughters that's informed me that this was a dubious choice of clothes, and that's also been giving me marital advice over the last few years. I cannot be more happily married than that. Interesting enough, now, so this study also looked but at in-home video recordings, and I'll compare it now in the next slide. So what Anusha found is that in a clinical sample, there were less SP moment or shared pleasure moments. It's also important if we look at the impact that this has got on attachment. And it seems like when attachment is problematic, that your SP moments may be slightly less than expected. To go back to the marital advice study that's similar, what they found with in-home recordings of married couples is that if the wife presents with more mood or depressive symptomatology, she gets better support from her husband. A husband needs to present with some neurotic symptoms to get better support from her husband. So if you take nothing home tonight, at least I've helped you to improve your marriage to the same quality as mine. Okay. I don't know who of you remember Men in Black. Now in Men in Black, I really think I'm basically just Ambassador Rosenberg. Because there is a brain behind this operation. Professor Jukka Leppänen from Finland, University of Turku. So Jukka's been a driving force in this whole operation. And I also always think one needs to give credit where credit is due. He's a brilliant mind. He's the type of collaborator that you enjoy. And I still have to get him back for a few things he said about me, but let's leave it at that. And what Jukka looked at in his group is infant face preference. So infant face preference basically means the baby tends to prefer looking at faces and not at patterns. And we see whether the baby can be distracted from looking at faces. And what the study found, and this was a study done in Finland, Malawi, and South Africa, is that babies tend to disengage slower from faces. Much slower than it is from a pattern. Plus, when you look at the disengagement, they seem to disengage slower when the face was fearful instead of happy. And this is fundamentally important for the survival of the infant, because fearful adult faces may indicate that somewhere in the environment there's a stressor that needs to be addressed. The other message we can take from this, which is a dubious message, is if you want babies to look at you, just appear fearful. But reduced facial preference can also be a problem. And this is related to a concept called callous unemotional traits. So callous unemotional traits can be summarized as meaning that you've got impaired emotion recognition, that you've got the impaired ability to respond to others' distress, and that there may be a bit of lack of guilt or empathy. And there's different models for callous unemotional traits. I would like to point out to my PhD candidates that I do not have high callous unemotional traits. That's a myth. Why is callous unemotional traits important? It's important because we find it in all of these cohorts that's been studied. And this just gives an indication that even in the South African cohort, there's a smaller percentage that seems to have these callous unemotional traits. Why it's important for us to know is that they may be less able to benefit from parental sensitivity, making the compensation for this slightly more difficult for mum. So when we look at this disengagement from faces versus the CU behavior, we can see that also in the South African and Finnish sample combined, that we see the same pattern where there is quicker disengagement from faces, the higher your callous unemotional score gets. Now I need to clarify this. The fact that your partner does not engage your face when you complain about the recycle bin, that's not disengagement. You can only disengage if you've actually engaged. I'm just throwing that out there for any guest that's here. So now, what now? As my elders would always say, and nou, wat nou? Now we know, at least, that the risks are real and present. That pregnancy planning needs to be a focus for psychiatric services. That the late engagements of mums into maternal mental health needs to be addressed. That established risk factors for pregnancy outcome is available, and we should be cognizant of those. That there are developmental challenges in our cohort, but there's also opportunities for intervention. And then on the Ying side, I'm still hoping for a sponsorship to Finland. And secondly, we will have to buy many more marshmallows because we still have about 17 to 20 of our 4-year-olds to assess in the next year. Ladies and gentlemen, thank you very much for this opportunity to share the work of all the PhDs and collaborators on this project. And I would like to thank each one of them individually for the wonderful work that they've put in, for the enjoyment we had from research. Because if research ain't fun, it's not worth doing it. Thank you.
Thank you very much for the description. There are quite a number of acronyms we got from it. So yeah, I want to thank you, but my thank you will be a bit longer than usual. So, but first of all, I just want to say, okay, that was not the electricity going, sorry, colleagues, for that. I just want to take this opportunity, of course, to thank our speaker. Before I do that, I just want, first of all, to thank you for attending and to acknowledge, of course, as you know, I'm an administrator, so I have to go through the protocols, right? Just as part of the job, so don't get bored. We'll have a discussion soon after. So to thank the Dean of the Faculty of Medicine and Health Sciences, Professor Elmi Muller, to say thank you. The Vice Dean Research, Professor Nicole Van Pitius, thank you so much. And also the Executive Head of Department, Professor Sidet, yes, in front. Everybody knows you, right? I assume. Okay, good. All right, and then students, do we have any students present with us? Oh, thank you so much for coming. You know, you make the lecture look very interesting. It was interesting, but of course it's also good to know what our professors are doing behind the scenes. And then alumni, friends of Professor Dana Niehaus. I hope I got that correct. I'm also learning Afrikaans, so yeah. I hope I don't suffer from mental health in the process, given the talk that you were giving today. So yeah, and then also in particular, they say that behind every successful professor, there's also a successful wife and family pushing. So can I see where the wife to Professor Niehaus is? Is the wife present? Thank you so much. At least we heard what you do. He told us he has a perfect marriage, so thank you. And also the daughters as well. Thank you so much for joining us. And then, of course, today is a special day, as you know. The inaugural lecture marks, of course, the ascension of Professor Niehaus to the rank of full professor in the university. And we value that because as a university that is pursuing excellence in research, it is important that we have the right people in the right places, doing the right things and doing research that makes a difference to many, not just doing research for the sake of doing it. So congratulations to you for this promotion to the rank of full professor in the Faculty of Medicine and Health Sciences. And thank you for delivering the inaugural lecture on mental health, 40 weeks and 1,000 days. So, of course, it was really inspiring to me. I think some of the terms I got from today's lecture is the yin and yang of research. And then, of course, there were some other things. I didn't know about the London measure of unplanned pregnancy. I'm sure the people in the medical sciences know that already. I'm a mathematician, so that was quite interesting from my side. And of course, the eye is the window to the brain. That is also quite interesting to hear. And then the Duchenne smile. Is it Duchenne smile? It sounds French, but I don't know if it's French or is it Afrikaans?
No, it must basically be French, I guess, yeah, because for Afrikaans it's very difficult to pronounce.
Okay, so yeah, so there are a few terms that we got. Of course, for those of you who may not know, so I took some time yesterday just to check, on now you have Google, you can check on Google, but there's a tool we use normally for a Scopus database, which is cyber.com. Where I noted that if you look at just Professor Niehaus' track record over the last few years from 1993, were you still active in 1993? Yes. So I saw, yes, from 1993 to 2022, he has published a number of articles with an H index of about, the H index is currently 36, but the articles he has published over that duration have something slightly over 3,876 citations, which is a big achievement for someone in this rank. So I think we have to acknowledge that. And then, of course, between 2017, more recently, and 2022, he had 21 scholarly outputs with 67% of these which appeared in open access journals, of course, with 50 citations. But what is important to remark is that there's one article which I thought was quite interesting, and I tried to go and check this article. It's on the paper. It's a paper, if you check, on stigma, mental patient, and stereotyping, which has a field-weighted citation index. Excuse me, because I like numbers, so I'll explain what this means. It has a field-weighted citation index of 1.91. That just means that globally, the global average for these citations in this field, is around 1. So it exceeds that global citation by 0.91, which is well above the global norm. And that shows you the impact and quality of the work. It's just one paper that I looked at. There were others, but of course then ESCOM came, and I was in the dark. And thank you for that. But then, of course, if you look at that, there's been other work which is done. And I think when you look at the fields where it's made an impact, it's not just in around the work it's doing, but it's also interdisciplinary, because the impact that shows a lot of the work, of course, his contribution has been on psychiatry and mental health, and then also followed by public health and environmental sciences. There's obstetric and gynecology as well, because of the type of work it does, and then family practice. You may not know that, but it is on Scopus. It says that that's what you've done. So that, and then there is also the pediatrics and perinatology, okay, and the rest, of course, are spread out in terms of rehabilitation, reproductive medicine, and also, gerontology. I think it's defined like that. It's all the fields. So this type of classification, of course, depends on the tool that we are using, but I didn't use the Web of Science. But what I wanted to say is that all the indicators of someone to reach this level in terms of being a successful publisher, but also, mentoring students, supervising students, publishing, the quality of the research, and then the impact of this work that it would have on also our community, and not just for the sake of publishing. Of course, for the university ourselves, we are glad that from the university management, my role was to thank you on behalf of the university. But you are an example, of course, of someone who has been able to contribute to the success of this university, which is obviously enjoys its ranking. We are ranked, but we are not ranked just because of a few people do research, but of course it's also the collaboration which counts, collaborating not just with our local people, but also beyond our borders. So internationalization is a key component on that. So I want to thank you, lastly, for sharing the body of knowledge that has constituted your progression to this rank once again, and the research that has touched a number of areas in medicine that have been mentioned. And congratulations once again. So I want to ask the people who are sitting, because to thank him. I don't think we thanked him a lot. So we have to stand up and then just thank him for now being called Professor Niehaus, the full professor in medicine. Yes? Thank you so much. Can you stand up and clap for him, please? I think if you ask our corporate affairs, they'll tell you that the clap is, I think if we have to classify claps, it's not really like it's disconnected. It's not loud enough. And I think he feels sad because if you remember the definition of his smile, what is the best smile? What was the optimum best smile? Who remembers? The attendants. What's the best smile? What is the name of the smile that is? You can say it louder. Duchenne smile. Now we are going to do a Duchenne clap, okay? And the Duchenne clap is also much happier than what it sounded. So please, note that he spent many hours. You may think the lecture was short, but you can, believe me, there's a lot that goes behind the scenes. So we're going to give him a Duchenne clap and say thank you very much once again. Can we try that? Okay, thank you so much. And then we have, we don't have to do the picture again, but you can stand over there so that people see you. And the wife and the family, that this is the reason why he is always spending hours, too many hours at work. But thank you so much and congratulations.
Thanks, Prof. Appreciate it.
Thank you.
Thank you, Professor Moyo, and thank you very much, Dana. A wonderful lecture, and really enjoyed it. Colleagues and friends, family, we are now nearing the end of our event. All that remains for me is to thank the organizers, especially Megan, Salon, and anyone who helped you in the Marketing Communication Division for the overall organization. Menwin, thank you very much for the audiovisual assistance, Mr. Justin Alberts for the videography, Russell Anthony for facilities preparations, and the campus security for their assistance, and everyone else who contributed to making this a special evening. So with this, I declare these proceedings closed, and would like to invite you all for some light refreshments in the Dean's reception area just down the passage. And thank you very much all for coming. Enjoy the rest of the evening, and please drive safely. Thank you very much.